or angiography enough? Thank you.
Thank you very much. Salam alaikum. Happy Kamawachan. So I'm going to be talking about complete revascularizations in chronic coronary artery disease and acute coronary syndrome. Do we always have to use physiology, FFR, and so forth, or is angiography enough? So when we talk about complete revascularizations, we have to distinguish whether you're talking about anatomical revascularization or physiologic functional revascularizations. When you talk about anatomical revascularizations, you will take any lesions of more than 1.5 millimeter in diameter vessel with more than 50% diameter stenosis, and you just deal with it. Or if you want to go by functional revascularizations, then you would actually look for lesions in which there's evidence of ischemia or hemodynamic significance in either localizing invasive or non-invasive tests, regardless of the physical anatomical severity. So we all know from the way back syntax trial that complete revascularization, whether it is with PCI or whether it's CABG, is associated with a better outcome. So incomplete revascularization, worse outcomes. And those trials was actually based on angiography. So an angiographically determined incomplete revascularization has a detrimental effect on long-term clinical outcomes, including mortality. But we need to look actually at this subject topic in different groups of patients and look at the data. So I'm going to divide them into STEMI patients and STEMI patients, cardiogenic shock patients, and stable CAD, and see whether physiology is needed in a complete revascularizations. So when we look at the STEMI trial, it is quite clear from the early trials of primary, culprit, and pre-multi trial that if you adopt a strategy of a complete revascularization, treating the non-culprit lesions, whether doing the index procedure or subsequently as a stage procedure, is always better than just treating the culprit lesions alone. Particularly when you look at culprit trial, 5 years follow-up, there was a significant reduction in mortality, which is a hard endpoint for patients with complete revascularization. But what about physiology? There were actually 2 trials in the primary PCI patients using FFR to assess the non-culprit lesions. The 2 trials were Dynamic 3 Pre-Multi and Compare Acute. Both of these trials actually shows that FFR directed revascularizations of the non-culprit lesion was beneficial in terms of reductions of composite. But when you look specifically at the endpoint, they were all good for the reduction of a reduction. They were all good for reduction in repeat revascularization. It doesn't lower mortality, it just reduces the likelihood of patients requiring subsequent intervention. Then there were also another 2 trials called the FIRE trial and the FRAME AMI, where they use FFR again to assess the non-culprit lesion. Now, both of these trials now shows that there is a composite benefit, but it's a composite event driven by a combination of ischemic endpoints, but both were positive trials nonetheless. But there were 2 negative trials that if you use FFR to guide in the intervention of the non-culprit lesions in the FLOWER AMI trial and the full revascular trial, actually a FFR-guided strategy of the non-culprit lesion did not reduce subsequent risk of composite event. So what's happening here? So when you combine the FFR-guided and the angiography-guided clinical trials and you put them in the meta-analysis, you can see that for one, complete revascularizations, whether it's angiographic-based or FFR-based, is associated with a lower incidence of adverse events. But FFR-guided complete revascularization at this point in time is not superior to angiography-guided complete revascularizations. So why is this so? Perhaps we are actually looking at different things. When you use FFR to guide your interventional decision, you're actually looking at flow-limiting lesions causing ischemia. But when you use angiography to guide your intervention, perhaps you're looking at the complexity of the lesions and perhaps also some parts are related to the plaque vulnerability. So maybe we will need a complete 2 trial to finally answer the questions of whether we need to do a FFR trial guided strategy for all non-culprit lesions in patients with STEMI and multivascular coronary artery disease. What about NSTEMI patients? The data for NSTEMI patients, complete revascularizations is far more deficient. The only one of the trials that I can pull out, which is way back, called the ACUITY trial, where you look at bivalirudin in patients with ACS. And in this particular trial, sub-analysis suggests that the incomplete revascularization was strongly associated with ischemic outcomes. But when we look at all the other literature, many of the trials were actually observational, non-randomized. So at this point in time, our understanding of complete revascularization in end-STEMI patients with multivessel disease is still somewhat lacking. What about cardiogenic shock? Do we actually have to pursue complete revascularization? I think this question has been pretty aptly answered by the culprit shock trial. Culprit shock trial tells us that when you randomize patients into either culprit lesions treatment, primary PCI in cardiogenic shock state versus multivessel PCI, at 30 days of follow-up, there was a higher mortality with complete revascularization. There was a higher risk of patients having renal failure requiring renal replacement therapy from day 3 onwards and so forth, suggests to us that in cardiogenic shock patients, perhaps no need to go for complete revascularization, just treat the culprit lesions. But this culprit shock trial was performed in an era where there was no hemodynamic support in these patients. So in the current context of Danish-German shock registry, where Impeller now has been shown to reduce mortality, we will probably have to reassess and re-examine this subject again. Finally, with patients with stable coronary artery disease, what do we do in patients who have stable CAD and multivessel disease? Do we have to put in an FFR to guide in our treatment? And this question was actually way back addressed in the famous trial called the FAME trial. For FAME trial, look at patients with stable coronary artery disease and then divide them into two arms, FFR guided and prove ischemia before intervention, and the other one is based on angiographic assessment where there is a 50% narrowing. I'll just go ahead and fix it. The outcome of the FAME trial is quite significant. At 1 year of follow-up, if you do a FFR guided strategy, you actually reduce the number of major adverse cardiac events. The MACE-free survival is far superior to that of an angiography guided. In fact, up to 2 years, we were still seeing the benefits of FAME trial. But from 3 years to 5 years of a FAME trial follow-up, there was actually no difference, suggesting us that perhaps this FFR guided strategy is probably good in the initial medium to short term. Then we have the FAME2 trial. FAME2 trial tells us that when you have a patient with stable CAD, you put in an FFR, it is positive, you do a PCI versus a group of patients where you just leave them on medical therapy. FFR guided PCI strategy actually brings about better benefits in terms of reduction of composite of death and MI and urgent revascularizations. So this pretty good, sounds good, but until the FUTURE trial came on. FUTURE trial is a trial that was carried out in multiple French centers comparing two strategies, again, FFR directed versus angiography directed in patients with stable CAD, and you find that there was now no difference in terms of the primary endpoint. So we are a little bit confused here as to whether there's a role to put out a FFR pressure wire in all our patients with stable CAD and multiple lesions. What FUTURE trial also tells us that when you look at the patients with FFR-directed strategy, there was actually a higher mortality, particularly those in the very complex anatomy with syntax score of more than 32. So what does the guidelines tell us then? The guidelines tell us that from the European guidelines, when you have a patient with stable CAD, some symptoms, and then the non-invasive restratification risk is high, perhaps you want to consider invasive coronary angiography guided by FFR. So in conclusion, ladies and gentlemen, I think what is quite clear to us is that complete anatomical revascularization does improve the clinical outcomes in the long term. FFR-based strategy for complete revascularization decreases the rate of revascularization. But then treatment decisions based on FFR have not been shown to have any significant improvement in clinical outcomes compared to an angiography-guided strategy, which is now still the standard of care for both ACS and stable CAD patients. And for this, I think we probably will need a future randomized trial such as COMPLETE-2 trial to really address the role of physiologic assessment in the complete revascularization patients with multivessel coronary artery disease. With that, I thank you very much for this, your attention. I would like to thank Dr. Mohsin for this kind invitation to this meeting and look forward to welcoming you all to Singapore for for the AICT Asia PCR meeting from the 4th to the 5th of October. Donaba, Dr. Hobe.
Thank you. Any comment from our